24 years old only housewife came to the maternal clinic in a private hospital in India. She had no comorbidities. She delivered a baby via vaginal route with no intranatal complications. The baby was female, weighing 2.7 kg. Baby cried immediately after birth with first minute Apgar score of 5 and fifth minute Apgar score of 7. After birth, baby had respiratory distress but not required any resuscitation. In suspect of respiratory pathology, baby was referred to tertiary care center for further management. On physical exam, there was a presence of respiratory distress and tachypnea with respiratory rate of 70 per minute, moderate subcostal and intercostal retractions. Air entry was reduced on the left side of the chest and ball sounds are heard on the left side of the chest with no crepitations. Heart sounds were better heard on the right side of the chest without murmur, and there was a scaphoid shape of abdomen. Chest x-ray is showing left hemithorax is filled with cyst-like structure. Loops of bowel, the mediastinum is shifted to the right and the abdomen is relatively devoid of gas. So this was a case of congenital diaphragmatic hernia. So in today's video we are going to learn about congenital diaphragmatic hernia. CDH is a rare condition. It occurs 1 in 2500 to 1 in 5000 live births. 85% it is on the left side, 13% on the right side. 2% of the patients might have bilateral lesions with complete agenesis. 40% of the cases there are associated anomalies. Congenital diaphragmatic hernia is congenital defect in formation of the diaphragm allows the abdominal organs to push into the chest, leading to lung hypoplasia and pulmonary hypertension. The diaphragm is a sheet of internal muscle that extend across the bottom of rib cage. It separates thoracic cavity, heart, lung and ribs from abdominal cavity. It performs an important function in respiration. Normally there are 4 developmental sources of the diaphragm, or it can be said that 4 structures are needed for the development of the diaphragm, and they are septum transversum, pleuroperitoneal fold, esophageal mesentery and muscular ingrowth of body wall. This structure they come together and fuse with each other to form a complete diaphragm. If somehow one of these structures do not develop or is absent, or they do not fuse with each other, then a gap or defect. In this picture we can see a gap or defect. Through this defect the abdominal contents can easily enter into the thorax, and this is how the herniation takes place. These organs in the thorax compresses the thoracic structure like the lungs and the heart. For this compressions, the lungs will not be able to grow properly, especially on the side of compression, and this is known as a pulmonary hypoplasia. That means lungs are undersized and underdeveloped and small in size, so baby will face difficulty in breathing. There are fewer alveoli, thickened alveolar walls and increased interstitial tissue and markedly diminished alveolar air space and gas exchange surface area. There are reduced number of vessels, adventitial thickening, medial hyperplasia. They lead to variable degree of respiratory insufficiency and pulmonary hypertension. Pulmonary hypoplasia can lead to airway changes, vascular changes and interstitium changes. So all these factors together will lead to left ventricular hypoplasia, can lead to right to left shunting, hypoxia, hypercarbia and acidosis, and further it will cause pulmonary arterial vasoconstriction, pulmonary hypertension and pulmonary interstitial emphysema and pneumothorax. So these babies are prone to have a air leak syndromes, that is pneumothorax. There are several types of CDH. Among all, Bordel-like hernia is the most common one, and apart from Bordel-like hernia, we also have the Morgagni hernia, central tendon defect, as well as diaphragmatic eventration. Now, Bordel-like hernia, it is the most common manifestation of the CDH and it accounts for more than 95% of all cases of CDH. And this hernia takes place through the Bordel-like triangle. This triangle is situated between lumbar origin and the costal origin of the diaphragm. There are 3 origins for the diaphragm: sternal origin, costal origin and lumbar origin. Lumbar origin means it is portion of the diaphragm arising from lumbar vertebra. Costal origin means the portion of the diaphragm that is originating from the costal area or the ribs. This triangle is situated between lumbar origin of the diaphragm and the costal origin of the diaphragm. This is why this triangle is also known as a lumbo-costal triangle. Great anatomist and pathologist Vincent Alexander Bordel-like first accurately described about this triangle, hence it is known as Bordel-like triangle, and herniation through this triangle is known as a Bordel-like hernia, lumbocostal hernia or a postolateral congenital diaphragmatic hernia. This defect mostly takes place in the left side. They may take place on the right side as well, but usually find this is on the left side. Now the Morgagni hernia, this is very rare condition accounting for approximately about 2% of all CDH cases. In these cases, there is herniation through the foramen of Morgagni. These are small natural gaps between the external origin and the costal origin of the diaphragm. Hence, this foramen is also known as a sternocostal foramina. This is natural weakness in the anteromedial portion of the diaphragm caused by the passage of the internal thoracic vessels. They pass from the thoracic cavity through this diaphragm into the epigastric region. There they become superior epigastric vessels. This foramina, named for Giovanni Battista Morgagni, an Italian anatomist regarded as the father of modern anatomical pathology, who taught thousands of medical students from different countries during his 56 years as a professor of anatomy. He noted this condition while performing post-mortem examination on a person who died of gangrenous colon which herniated through this foramina. On his name, this foramina is named as foramina of Morgagni. Another interesting fact, Larry's Napoleon surgeon, he described a surgical approach to the pericardial sac through this foramen. That is why this foramen is also known as Larry's space. So this foramen is known as foramen of Morgagni's sternocostal foramen and Larry's space. Now diaphragmatic eventration, there is abnormal displacement or elevation of part or all of an otherwise intact diaphragm into the chest cavity. This thinning is thought to occur because of incomplete muscularization of diaphragm. In most of the cases, the causes of CDH is not known. In some cases, CDH can be linked to a genetic disorder or a random gene changes called mutation. Turner syndrome, Down syndrome, Edwards syndrome, Patau syndrome, Pallister-Killian syndrome are several among syndromes in which the CDH may occur. Some of these syndromes are caused by changes in the single genes and others are caused by chromosomal abnormality that affect the single genes. I have made a very beautiful video on Turner and Down syndrome. Link is in the description box and there is I button. The majority of CDH cases are identified prenatally between 18 to 24 weeks of pregnancy during a standard anomaly scan. CDH is distinguished by the visualization of thorax filled with abdominal content and the mediastinal shifting from the defect to the contralateral side in prenatal imaging. Associated anomalies are present in high percentage of fetuses. Almost approximately 40% have been thought to compromise survival. 59% antenatal detection with average age of 24.2 weeks. The milder cases, on the other hand, as in our patient, might not be discovered until later due to minor defects, and prognosis of CDH is influenced by the extent of lung hypoplasia, the location of the liver, and coexisting abnormalities. Fetal lung volume is measured by the lung to head ratio, which is obtained from the contralateral lung area divided by the fetal head circumference. Fetal lung to head ratio measurements have been used to predict neonatal pulmonary hypoplasia. The value of ratio is very important. All newborn died if the ratio reaches 0.6. On the contrary, they would survive better with survival rate of 100% if the ratio is reached above 1.4, while the ratio between 0.6 to 1.4 had a survival rate of 65%. Liver position referred to whether or not portion of liver has herniated or gone up to the chest of the fetus. Fetus with liver up in the chest have more severe form of CDH and a lower survival rate. Liver down CDH babies have a good chances for survival rate. There are other risk factors to predict poor outcome. Those are antenatal factors of prenatal diagnosis, polyhydramnios, right-sided defect, chromosomal abnormalities, as well as congenital cardiac anomalies. More than half of all CDH cases are discovered prenatally in second trimester. Postnatally, large diaphragmatic hernia usually present with respiratory distress, cyanosis, decreased breath sound on the affected side, displaced heart sounds, and scaphoid abdomen. Some of them will also present as a large anteroposterior diameter of the chest. On the other hand, small defects may have a delayed presentation with mild respiratory distress or feeding problems. So generally there are three types of presentation. Severe respiratory distress at the time of birth indicate the severe hypoplasia. Respiratory deterioration hours after delivery, which is also known as the honeymoon period, benefit from the correction of hypoxemia and pulmonary hypertension, while feeding difficulties, chronic respiratory disease, pneumonia, intestinal obstruction within 24 hours of the birth, it signifies it is a small defect and it has a best prognosis. Fetuses with moderate or severe CDH are eligible for a prenatal fetal therapy called fetoscopy, endotracheal occlusion, or a feto, open fetal repair repair of CDH were having a technical complications and a higher rate of premature labor with poor outcomes, so open fetal repair for CDH was abandoned. So fetuses with moderate to severe CDH are eligible for a prenatal fetal treatment called fetoscopic and endotracheal occlusion or the plug the lung until it grows. Technique was reported to be able to reverse pulmonary hypoplasia in CDH. A foam plug or titanium clip is used. This procedure is typically performed at 28 to 30 weeks of gestation for severe pulmonary hypoplasia or 30 to 37 weeks of gestation for moderate pulmonary hypoplasia. Using a small camera introduced through a maternal abdominal wall and into the uterus, a small balloon is placed in the trachea. This intentionally blocks the fetal airways, which prevent fluid from leaking the lungs. As the lungs become inflated with fluid, lung growth is stimulated. Faster lung growth leads to better lung function at birth, better chances of survival. Trachea can be unplugged using the acute intrapartum tracheoplasty, which is known as the exit procedure at the time of birth. Exit involves partial delivery of the fetus during a cesarean section, allowing fetal airway to be secured while fetal oxygenation is maintained by placental perfusion. Prenatally diagnosed cases of CDH without any prenatal management, it is recommended to place a nasogastric tube after delivery for decompression of stomach and intestine. If the infant has respiratory distress, avoidance of begin mask ventilation and prompt intubation should be performed. The rest of the delivery room management should be in accordance with the current neonatal resuscitation program guidelines. Ventilatory management in NICU. Avoidance of ventilatory induced lung injury with gentle ventilation strategies is the cornerstone of respiratory management in infants with CDH. Maintaining the preductal saturation in the range of 85% to 95% with peak inspiratory pressure less than 25 cm of water, positive and expiratory pressure of 3 to 5 cm of water, and targeting PCO2 in the range of 45 to 50 mm of mercury range is a reasonable strategy to mitigate lung injuries. High frequency ventilation should be considered if adequate ventilation oxygenation cannot be achieved using a conventional ventilator. There is no role of surfactant. Management of pulmonary hypertension is recommended to obtain an echo on suspicious of pH or within 48 hours to assess the pulmonary vascular pressure. Management of pulmonary hypertension includes optimization of ventilatory strategy to target adequate ventilation and oxygenation, maintaining systemic arterial blood pressure in the normal range with the use of vasopressor if needed, and the use of pulmonary vasodilator to increase pulmonary blood flow as needed. Inhaled nitric oxide, which is selective pulmonary vasodilator, is the first line of choice in the medical management of pulmonary hypertension in babies with more than 34 weeks of gestation. Milrinone, a phosphodiester 3 inhibitors, is helpful in infant with coexisting left ventricular dysfunction. Other drugs such as sildenafil, PGE1, PGI2 are also used to treat pulmonary hypertension with variable success. ECMO is considered to be the last resort option for eligible infants who are unresponsive to conventional medical management. Today, surgical repair is usually delayed at least 48 to 72 hours after birth to allow time for adaptation of pulmonary vascular and improvement of pulmonary hypertension. Children whom pulmonary hypertension is severe, surgery is delayed further until pulmonary hypertension is adequately controlled. The surgical approach to CDH has historically been through a subcostal abdominal incision. Minimal invasive surgery has become increasingly popular over time, and many CDH repairs in the stable children are now done thoracoscopically. After the diaphragm is repaired, almost babies can start to receive nutrition within a week or two after surgery. So, prognostic factor for CDH are lung to head ratio, associated congenital cardiac disease, associated chromosomal abnormalities, herniation of the liver, birth weight, 5-minute Apgar score, severity of pulmonary hypoplasia, and the presence of pulmonary hypertension. Chromosomal and congenital heart disease negatively impact the outcome of the CDH. Isolated CDH, 60 to 70% survival are reported by few centers. Long-term follow-up is required because these babies may develop gastroesophageal reflux disease, foregut dysmotility, chronic lung disease, scoliosis, pectus excavatum, cognitive skill and developmental delay, and seizures. So conclusion is CDH is a congenital anomaly with high mortality, usually associated with pulmonary hypoplasia and hypertension. Surgical repair is the only treatment, and delayed surgery until the patient is stable is associated with better outcome. The treatment of congenital diaphragmatic hernia will require the team efforts. Thank you for watching my video on congenital diaphragmatic hernia. I hope you all understood and learned well. Please let me know what other topics you would like to learn from me.